hole in their chest. So as Tug was saying earlier, we train all our staff. We're going trauma-ready training. So as you can see, Paul's there cutting the t-shirt off, exposing George's chest, and you can see that he's got a large wound to the chest. So nice and simple. Just going to open up the trauma-ready training, get out the blue Russell chest seal. Opening up the Russell chest seal and applying it to George's chest. Covering the large wound.
This is free waxing.
Somebody's rang 999. And ensuring an ambulance comes. When you have penetrating chest trauma in the UK, it will signify that an ambulance response needs to arrive within 18 minutes. It will also signify that a critical care level 8 team attends as well. So, very fortuitously, we have a level 8 critical care team who are going to attend the incident within about 30 seconds. So the critical care team will be made up either by 2 critical care paramedics or a doctor and a paramedic. Highly trained individuals dealing with the most critical, unwell patients. The ambulance service do a phenomenal job for about 95% of patients, but for that top range of patients who need advanced care procedures, these critical care teams can attend. So we've got Tom and we've got Sarah from Midlands Air Ambulance who are going to perform a primary survey on the patient, ensuring that the airway is clear of the patient, following through that CABCDE assessment process.
No, it's right. If you could stay here, you can help us, that'd be great. I'm going to turn the monitor on. Do you have a pulse?
You have a pulse, Tom, and that pulse is fast and very thready. You've got a rate of approximately 160 beats per minute.
Primary survey, you're right to put the monitoring on. Brilliant. Fab. So, I'll talk as I go through. So, head is fine.
No injuries to the head.
Okay, so chest we have.
Chest, you've got the large wound underneath the Russell chest seal, which you can see and covered up.
Okay, crepitus.
No crepitus to the chest.
No. Breaths.
You've got increased rest rate, about 40 breaths per minute, shallow.
His trousers up for you, take his socks off. Thank you.
So why do you have to go on, okay?
Brilliant. Can I just, while you're doing that, I'm just going to quickly turn him to look at his back. Yeah, ready, steady, go.
So having a look at the back, you can find no other wounds, Sarah.
No wounds.
Single wound to the chest.
Single wound, penetrating chest, left side of the chest.
Hi, Dan, you're right.
George has been reinvented as a paramedic, which he is.
Can you manage the airway?
Lazarus.
You monitor here.
Yes, please.
So getting the patient as exposed as much as possible, making sure there's no other injuries that are hidden to the patient. There is no other injuries to this patient, just a single wound to the chest.
Yeah, so we've got the IO kit, that's all right.
Access-wise, as I described earlier, so they're not going to go IV, they're going to go direct for IO in a traumatically injured patient in the humeral head.
So we've got that just in case. Thank you. Perfect.
So oxygen is on, patient is breathing really quickly, really shallow.
Okay, so just reassessing then if we've, so respiratory rate,
Respiratory rate is about 60 breaths per minute, really shallow.
about 6, okay. Have we still got central pulse?
You have got a very weak, thready central pulse, both femoral and carotid.
IO's now there.
Okay, so Tom, we are perio rest,
Okay.
so let's manage the airway. If we can put an eye gel in, I might ask you just to provide some bag valve mask ventilation, if that's okay.
Sarah?
Yes?
While you do that, do you want me to get some thoracostomies left and the right side?
Yeah, brilliant.
Okay, there's one for you.
Patient has gone into a low flow state.
Okay, so we're
They're
in
tolerating that eye gel.
Okay, so
You still have a very weak carotid pulse.
so if I get an end tidal log, forward, is that okay? Yeah.
Patient is ventilating well with the bag and mask and the eye gel. So as I was talking about earlier,
So we do.
critical care teams will do thoracostomies to try and alleviate any form of traumatic cardiac arrest. So Tom's just prepping there to do a thoracostomy on the patient's left side. while Sarah prepares her kit to do a patient thoracostomy on the patient's right side. Everything we try and do is as sterile as possible. So this isn't in a hospital, it's in a dirty warehouse, but we still try and do it as cleanly as possible using iodine if any surgical techniques are done.
If you're happy, so we're going to do some thoracostomies now if you're happy with that.
Tom's performing a thoracostomy on the left that you can see there, fingers going in, sweeping in. As it goes in, making sure that all the tissues are separated. He's trying to feel to see if the lung is inflating and deflating as it should. There's a large hiss of air and a bit of blood coming out that side, Tom, as you put that track in place.
Have we still got carotid?
Have we still got a carotid?
You have a slight carotid, very weak.
Okay,
Lung is up.
Just doing the sweep.
Lung is up on the left and the right with ventilations.
Okay, so thoracostomy is performed.
You notice a change in rhythm on the monitor, and when you palpate a carotid pulse, you now cannot feel a carotid pulse.
Okay, so Tom, we are in a complete lost state, so I think we need to continue to afford thoracostomy.
Okay, that's fine. Are you happy to do a single cut?
Yes.
So they've declared that they're going to do a thoracotomy on this patient. So with traumatic cardiac arrest, there's a number of causes to that cardiac arrest. It might be blood flow, it might be a tamponade, which is what I was talking about earlier regarding the blood being in that pericardial sac, stopping the heart from beating. So to try and alleviate this, they've done the thoracostomies, just in case it's attention pneumothorax. That hasn't changed anything in the patient. So what they're going to do is a single scalpel incision across the skin of the patient, going from right to left or left to right. And then what they'll do is, utilising tough cuts, is follow the same track, cutting in the intercostal muscles.
Meet in the middle.
Yes.
And they'll meet in the middle of the sternum, cut through the sternum, and then they'll be able to open and get access to the patient's vital organs.
Okay, just going around the sternum, through the sternum now.
Cut through the sternum. Right.
So utilising George's massive left bicep, he's going to hold the ribs open.
Don't worry about leg at the moment.
And you can see inside the chest there, and you can see from this view that you've got a tamponade around the heart in the pericardial sac.
There you go, Tom.
Thank you. Perfect. Okay, so I'm going to pick out the pericardium. We've identified the heart.
Okay,
Yeah.
we do a T-shaped incision.
So a T-shaped incision in the pericardial sac.
Okay, we've got active bleeding.
See some blood clots around that heart.
We've got pressure on it.
Okay, we've got a finger into the hole and I'll get the staples.
So as you can see, it looks like a kit explosion from up here, but they know where everything is. You've got the rampart system in the bag furthest away from you. You can see all the different colours there. Very easy to utilise if needed. So staples going into the heart, closing that wound.
Yeah, so we're going to do some manual compression, George, and how do you...
Tom's doing some internal chest compressions. So just as you would do CPR externally, if you haven't got access to the heart, squeezing the heart between your hands to circulate blood volume around the body and hopefully get a return of spontaneous circulation, which hasn't happened as yet. No other injuries to the heart found, Tom.
Okay.
So I'm going to start squeezing the bag. I think if we do get a rostering filling, then we will proceed to fear.
So after about a couple of minutes of internal chest compressions, Tom feels some flickering of the heart.
Okay, what rhythm is on the monitor?
You've got a VF. Oh no, we won't say that. I won't be nasty.
He flicks the heart.
Yeah, he flicks the heart. Excellent. All right, cool. He flicks the heart, which gives a certain amount of joules that you get a rhythm compatible with life.
Okay, so that's good.
You keep on pushing that blood through.
You can probably put that down for a minute, and we'll just keep an eye on the monitor.
Monitor is showing a rate of 140. End tidal is on the iGel about 6.2. So now that they've got a return of spontaneous circulation, they need to anaesthetize this patient. This patient hasn't had any drugs as yet, So they need to give the patient some drugs to keep them stable, stop them waking up, which could happen because they're not anaesthetized. They've now got circulating blood volume around the body, to the brain, to the heart, to the lungs, which could make them wake up, so they need to keep them stable, give them an anesthetic, intubate, and keep them as kind of stable as possible for the transfer to hospital.
Surgical airway. I think we only have.
So all these procedures are what we call halo procedures, high acuity, low occurrence procedures. So really highly pressured, utilizing all your brain at the same time, utilizing and using up your bandwidth. So what the team will do is they'll use a checklist to make sure that they're not missing anything. You know, this is an anesthetic that you would get if you were going to have surgery in hospital, but they're doing it by the roadside, doing it in the pre-hospital setting. So utilizing that checklist, when they read through it, make sure that everything's in place before they go ahead and do the anesthetic.
So just checking, we've still got a carotid pulse?
We still have a carotid pulse rate of about 160 beats per minute.
Okay.
Right. 20 of ket. And is,
Are you happy to do drugs
yeah,
on the airway?
and 2 milligram per kilogram of rock.
Yeah, so how heavy is he? Is
About
it 80
80,
kilograms?
160,
160.
150.
Yeah.
No, 150 of rock, and then 30 of ket. 30. Fab, and I'll go into the, we've got a three-way.
It's attached, yes. So when are you happy to check this out?
Yes.
Okay, it's nice and loud.
Oxygen supply,
Is adequate and present.
BVM,
Is working, and I've got a good end tidal.
entitled blood pressure,
Blood pressure cycles reads 80 over 60.
We've got carotid
pulse oximeter,
is
SAT's coming back at 88.
ECG, heart rate,
Heart rate 140.
okay. IV IO access with fluid,
Running. We've got
Suction.
one.
IO is flowing well.
suction, working, laryngoscope,
is
Might be
size
tested.
yeah, and tested.
ET tube,
Is size 7 and
okay. Bougie,
size 15 and
okay. Syringe,
attached to
airway pouch,
Okay, so we've got the airway pouch here.
And he's got airways.
and different airway there. Okay. Conduction agent,
So we're going 30 of ketamine because he's light, and 150 as well.
okay. Different airway brief as required,
So I'm going to have one look. We've got a DL. We do have a VL if we struggle with any difficulties. If I can't have any, if I struggle, then Sarah, you have to take over.
Yes, I'm sure you will.
Be gutted if she said no, Tom.
Check's complete.
So time-wise,
Okay, so they've gone through the checklist.
30, 44, okay.
Then going to give the drugs that they need to. So it's normally ketamine and rocuronium for a pre-hospital emergency anaesthetic in the UK at the moment.
Flush, and I'm going to give some calcium as well. There you go. I've got adrenaline and metramine.
We'll wait for 30 seconds. If you're happy.
Okay, so drugs are being given. They've circulated around the body. Patient's fully apneic, not breathing, no muscle tone. Tom's using direct laryngoscopy to visualize the vocal cords. You can visualize the vocal cords. Bougie's going in. Bougie's through the vocal cords. Tube goes over the top between the vocal cords. They'll then inflate that cuff. And then they'll make sure that they're in the trachea, ensuring that they've got end-tidal CO2. They can see the lungs going up and down because they've got access, which they are doing. And that's all.
ladies and gentlemen, if you join me in giving Midlands Airways charity a round of applause.